So that was my first announcement. So this afternoon we're going to get together, and this is a sort of series of ideas. This is good practice sharing, which is really, really important, isn't it? Because if one of our teams across the country has success doing something, then to save us all working it out, then we like to share the good practice out, and you can take the learning from the good practice and you can see which parts of it would be suitable for your own practices. So this is what networking is all about. This is why we're here. So we're going to start with the Luton team from the lovely ladies here. So Denise and Sarah are going to give us a little bit of insight into how they've addressed the technology and the social deprivation, because I do think that this issue is now common to all. And if we can learn just a little bit from the Luton team that we can utilise in our own practice, then that would be great and really worthwhile you being here. So if you want to come and give us your presentation, that would be fantastic. Thank you very much, both.
So, good afternoon, I'm Diane Macey, I'm lead PDSN at Luton Experience Hospital.
I'm Sara Duable, I'm the administrator and I deal with the NPDA reporting.
Okay. So we wanted to talk to you about the way that we've improved some of the outcomes for our young patients. So back in 2021-2022, our NPDA report showed that we had low CGM uptake and also low pump therapy uptake in our local area. We also came out as a high social deprivation area and had high numbers of families from ethnic minority backgrounds. So in 2022-2023, we secured funding from the NHS England Diabetes Programme and Children and Young People Transformation Programme, with the aim to increase the uptake of CGM and insulin pump therapy for those who met the criteria of social deprivation and BAME background. We'd like to share our planning, implementation and experiences with you.
Okay, so to have a closer look at the 21-22 NPDA data, our low CGM, as you can see, L&D there on the left with the east of England here and England and Wales. So we were at 4.5 CGM uptake compared to 29.5 in the region and 31.5 nationally. And our pump use was at 23% compared to 33% in the region and 40% nationally. If we look at the service demographics, so you can see here Luton and Dunstable in the blue on the left, and you can see how overrepresented our patient groups are in these most deprived and second most deprived quintiles. So we had almost 60% of our families in those two most deprived quintiles, which was compared to 22% in the region in those most deprived quintiles and 45% nationally. And 40% of our patients are from ethnic minority backgrounds.
So we had a look at what we would use the technology funding for to help the uptake of technology for the deprived and those from ethnic minority backgrounds. We decided that a multilingual support worker would be really beneficial to get in to work with the families, that we would need extra admin time to make sure that our data was collated and could be used for things like this, that we needed extra dietetic support, and we used that as a locum because our dietetic team in the hospital were at capacity. We also wanted to use extra psychology support to support the children when we were doing these group sessions. We needed extra nursing hours to provide the education sessions for the families. We needed laptops for us to use out and about. And also we had the idea of having a mobile clinic using a van. So that was so that we could go out into the communities, meet people in their own area, save them coming into clinic as often. So at the outset, between January 2023 and this year, we identified those that met the criteria. We set up regular CGM workshops, had carb counting sessions with the locum dietitian, and had pump show and tell sessions so that the kids could be aware what pumps do, what they look like, and whether they thought that would be suitable for them. We recruited a support worker, and we did extra support activities. It had a huge engagement with schools. They allowed us access to the children during the school day, allowed us to go in, use our computers, download laptops, which was really, really important. And we had the idea, again, like I say, of the mobile van to go out and do the visits in the community to upload data.
Okay, so if we look at those who came onto the project, almost half of our type 1 patients met the criteria of being from those most deprived backgrounds or black and minority ethnic backgrounds. So we identified 88 patients at the outset of the project in January 2023. Throughout the year, then 12 of our newly diagnosed patients also met the criteria, so we added them into the project. And 2 of the original patients moved out within the year. If we look at, and then of those, of the 88 that we originally identified, 13 were already on pumps and 7 were already on CGM. Then if we look at the ethnicity split of the group, you can see those from white backgrounds here in the green segments, Asian backgrounds in the orange segments. The blue segments represent those from black backgrounds. These neutral tones at the bottom are those of mixed ethnicity, and the grey represents those who didn't disclose their ethnicity. And you can see the biggest single group here was white British, with the green segment, followed by Pakistani at 27%. This one here is white other at 11%, and then black African at 9%.
So we set out the group sessions. We held weekend sessions to start with the CGM. 7 sessions were done in the first 3 months, which was prior to us having a support worker. The sessions were really well attended. The kids could not wait to get in and get these CGMs on them. We started 84 young people on CGM within the project. We also then did pump show and tell sessions. These were also covered at a weekend so that the families could come outside of school hours, not miss more school time, but also because we needed the availability of a room at the weekend. We had 23 families attending these sessions, and then we offered individual sessions as well if the people couldn't attend to those group sessions. We had 24 young people started on pumps from the original outset, and there are 6 more waiting to go on pumps because their pumps haven't been delivered yet. So within the activities that we set up, the carb counting was virtual, so the locum dietitian offered virtual appointments, and these were only during term time. She couldn't offer any during the school holidays. Our support worker started with us last May. This helped us with going into schools, doing downloads, making sure that the kids were more accessible during the school working day, preventing time off of school. She also helped with setting up the carb counting on the apps and helping us with the CGM starts, and also was scheduling our appointments for us, booking the kids in to come to these sessions, so that was much easier. The input in the schools, as I say, was invaluable. She was then going in on a regular basis to see those that were a little bit more harder to reach to, so that we then got regular downloads, regular information about the children and their diabetes control. Unfortunately, the mobile van didn't come off. It was a really good suggestion. We looked at different vans. We had one that we could hire. We went out and looked at it. The company were really, really flexible. However, our support worker went back to her original role, which was a teacher. So we then didn't have the support worker. We decided as a team that it would be better off using a registered nurse as a support worker. So we redirected the funds to employ a registered nurse. And we now have that person as a registered nurse. The psychology input also wasn't possible. The resources within our psychology in the area just couldn't meet the criteria. They couldn't help us with that. So unfortunately, the children that come along to the sessions didn't have any extra psychology support. So at the moment, we are in the process of 12 other patients being through the education to be able to access pumps. So they've had carb counselling sessions, they've been through the show and tell, and they are in a process of deciding which pump they would like. The support worker is funded now until October this year, and the dietetic support that we have from the locum will continue until June this year as well. So our plans for the rest of this year is to provide more education sessions, particularly now on pumps, because we've got quite a lot now on CGM, is to make sure that we get those pumps started and make sure the kids are aware then of what pumps we offer locally. We're obviously all increasing our hybrid closed loop usage, so that's something we're also looking into, and we're helping to support the patients, but that technology is just the beginning.
Okay, so if we have a look at our outcomes, the purpose of the project was to increase technology uptake among the most deprived families and those from black and minority ethnic backgrounds. So among the group, the tech project patients, we've increased CGM use from 70% to 91%, and pump use has increased from 13% to 37%. If we go back then to the 2021-22 data and look at the impact on the full caseload, between then and now, so now we have 92% of our whole type 1 caseload on CGM and 48% on pump. And if we look back at that graph, you can see where we were and where we are now on CGM. Yay, thank you. Thank you so much. And for pump, you can see where we've gone from 23% to 48%, and as Denise said, more people still to go on. So you'd probably like to have a little look at our HbA1c. So this is for only the patients who were in the group through the full amount of time. So we can see the mean and the median there. It looks like there's a slight decrease, but we can't read too much into this, although it would be nice to infer lots of very pleasant things from this. Actually, it's incomplete HbA1c data. We don't have all the data points for all the patients. And we don't have anything to compare it to because there are too few patients within the group who didn't take on the CGM, so we couldn't make a meaningful comparison between them. I'm going to skip through that because I decided not to put it in. Sorry. Okay. Denise.
Okay, so from starting up on the CGM, particularly the benefits that we've noticed as the team is that we get more regular contact with the patient. We're not ringing them every 5 minutes saying, can you download your meter, can you download your pump? It's either automatically there through CGM or we've actually gone into the school to do it ourselves. So much better quality interaction with our families. We speak to them more often and there's much better relationship. I've found a lot more trust with the families as well. So we're able to do better dose adjustment. We use Libra 3 quite a lot. So the data that is there automatically. We've got Libra View on our screens all the time. So it's just there as available data. And the families reported back that they really, really liked the group sessions, particularly the pump show and tell sessions, and got a buzz out of being part of that. Parents' feedback to say that they're now getting some sleep, that they don't have to get up and check the child's blood sugar during the night, that it's a real improvement of quality of life for them. They've got a better understanding of the diabetes itself and that they're finding that their diabetes is coming under better control. And the benefits to the whole service is that from now, all children get CGM from diagnosis. We do that at the outset. Go to see them on the ward, they get a CGM sensor, as long as obviously they've got a phone. And all patients are now changing onto a more cost-effective blood sugar meter as well to try and feed a little bit back. So we just wanted to share a couple of particular patients with you to show their journey through this tech project. So this young lady was diagnosed back in 2021, obviously high HbA1c initially. She wasn't the most easy child to engage, shall we just say that. She had lots of issues overnight. Dad was always up, testing her blood sugar, and we had lots of problems when she came to clinic. She really didn't like coming to clinic. So beginning of last year, we popped her onto CGM with some protest, I must say. Anyway, she got onto CGM, and then we could all just see that general improvement as we contacted her more often. She was then improving on her blood sugars. We actually got her carb counting. She's had a pump show and tell session, and we're just waiting for her to go on a pump. And as you can see, her HbA1c has come down really nicely over that period of time. The other young lady came to us from Italy back in 2019. She was not far off of diagnosis when she came to us. There was a little bit of a language barrier, and she was quite young when she came over. So most of it was done through her parents. So her HbA1c did creep up quite a bit soon after she came to us. As she's then matured and got more interested in her diabetes, she started to take more and more on. Again, last year, we popped her onto CGM, and she also had carb counting sessions and a pump show and tell session. She was so keen to get on a pump. And so we gave her that, sort of real drive, say, come to these sessions, get the education, get that carb counting fine-tuned. We popped her on a pump, and her HbA1c is coming down lovely, and she really, really loves that pump.
So as we're coming towards the end of the presentation, we just wanted to reflect a little bit on what's really made the project a success. The first thing is really around the tech availability. So the ICB has made CGM much more available, which has made it really easy to get it out to as many people as we can as possible. The availability of Libra 3 is so small, easy to use, and we can order it directly. And also the kids just seem to love it, which has made all the difference. Ordering on BlueTech is much faster and easier than the previous route. And Dexcom readers have been really helpful for those kids who can't have a phone but do have some way to be able to download. It's been a really useful option. The ICB have been processing pump requests so quickly, and as it says here, some turned around within 48 hours, which is so helpful to keep the momentum up with families once they've decided. And actually, most families, once they were engaged, were willing and able to be able to get a mobile phone. So the tech is incredible, but it doesn't work and it doesn't deliver benefits without a lot of human input. And this is what has really driven the project. Extra staffing. So the nurses were working weekends to deliver the CGM sessions and the pump sessions. So in 2023, the nurses worked 214 hours over 10 months. And that doesn't reflect the time within working hours to manage and run the project, and also to then support the children when they're on their new technology. The support workers, Denise said, helping with the carb counting apps, the CGM apps, and the pump ordering, taking that load off the nurses. That was 532 hours over 8 months. That's between the two support workers that we had. And the extra dietetic support that we needed, all of this above and beyond what our standard service is, to be able to get the children in a position to be able to use the technology. That was 109 hours over 6 months. And we have to mention the school engagement, because as Denise said, the schools were absolutely excellent, so helpful and supportive in allowing access to the children, making themselves available for training, and allowing us access to their IT facilities.
So, as ever, there's so much more we could do. So, if we also had a support worker with the language skills to help to translate to the families whose first language isn't English, to have dietetic support in-house, face-to-face, but also during the school term during school holidays, not just in the school term. to have mobile phones for the families that really can't afford them, you know, that they are either worried that their young person is carrying a mobile phone and they're quite young, or that they, as a family, can't afford that. To actually try and get some psychology support for these kids. They were changing so much in quite a short space of time. A bit of psychology would really help them along the way. Although the van didn't come off, it was quite a unique idea, and we've still got it in the back of our heads for future planning. And the resources to support these families should be as standard. It shouldn't be just from, you know, a tech project. It should be there to engage all of our families and try and help with the uptake of CGM and pumps. Thank you for listening.
So, absolutely fantastic, yeah. I know you said that the outcomes, you didn't have the A1C, but you actually achieved what you set out to do. And that's the important thing. Your primary endpoint was improving the access. It wasn't to see whether the outcomes have improved. So you did succeed brilliantly. So really well done for that. Very impressive. This is what we all need to be doing. And I just commend you, because we need you in every service, don't we? We need somebody doing data, processing the data, analysing it, telling the team how well they're doing, and doing it accurately and with pride in their work. And not all of us have this sort of admin support across the country, and I think it is something that we need to stress. Fully and I were just commenting on this as an opportunity with HCL now to really major on the role of administration to help with the ordering, the tracking, the submission to get reimbursement. So this is our time for admin, I would say, and we need to be following your lead. So brilliant work. Questions?
Privilege of already having a microphone to ask the first question.
Well done, Molly.
Congratulations on what you've achieved. Like, there's so much to pick up on from that presentation, but one thing that I was fascinated by, you said you did not get the van ultimately, but the fact that you almost got a van blew my mind, because I hear from teams who can't even get an iPad to collect prem data from, and you were shopping for vans. Please, can you explain how that even entered the realms of possibility?
So our dear consultant, that's been his wish for I don't know how long, Ronnie. Yeah? So it was his brainwave, and we discussed it as a team. And then when we were awarded the funding, that was something we thought, yeah, we can make a difference. We can go out and we can go to different community settings. And Sara was the one that did all the groundwork in looking into the costings, looking into what van would be suitable. You really did that. You know, I did a lot there, didn't you? But unfortunately, because we needed to reroute the funds to elsewhere, we didn't go through with it. But again, the company were great as well. They were very open to what we might be using it for.
And can I ask one question to you, not about the van?
Yeah.
But I think what others may want to say is, when your funding comes to an end, you're going to use your data to show your improvements. How confident are you that your trust will support you going forward to continue this fantastic work? That might be something for consultants to join in, but this is the thing, it's sustainability funding.
So this we are going to present to our ICB and to the local, the hospital board. Yeah. We're definitely taking that forward.
Yeah, so well done for generating that, because that's what we worry about, that Fully and the team give us money, Fully. I don't want you to pump prime and see how it goes, but not in a position to sustain. And it's using your evidence, isn't it, to try and convince people it's a good thing to do. So well done, really excellent. One more, anybody else want to? Oh, Fully, yep.
You stole my question.
Oh,
sorry. But I've got a follow on. But first of all, though, I was just messaging somebody from the project team. We both at the same time went, "It's the van project." We got really excited. But absolutely amazing work, and I'm so impressed with what you've achieved in such a short space of time with not that much money, actually. So I think really, really fantastic work. But I suppose following on from Fiona's question, because it is great when we can get these pots of money to make a difference like this. But do you feel like you've learnt any lessons in terms of sustainability that doesn't cost anything? Do you feel like anything has changed in your practice that other teams could learn from, for example? Because I know your starting point was, you know, you had really low tech uptake, and now you've done an amazing job to get up to a really good level. What lessons do you think you've learnt that will carry forwards in your practice?
I think the one thing that we found really beneficial was the group sessions. And although, yes, they were funded because we did them outside of our normal working hours, the group sessions were a real key because you can get a lot of people on CGM at the same time. And like we said in the presentation, the availability of Libra 3 changed everything because it was cheaper, it was more available, it was really easy to use, and it's straight onto the LibraView data that we can see on a regular basis.
Well done. Excellent. Well, another clap for you. So well done. Keep going.